Hello, my name is Sarah Welch. I am a fourth year medical student at Chicago College of Osteopathic Medicine at Midwestern University in Downers Grove, Illinois. Here we present an interesting case about a patient with vertigo while incidentally found to have COVID-19 infection and was later found to have suffered from cerebellar stroke. Vertigo is known to be one of the most difficult symptoms to assess in the emergency room, especially in the case of isolated vertigo when there's no other symptoms to help differentiate an underlying etiology. And this challenge has many times led to delayed or misdiagnoses of posterior circulation strokes in particular. In addition, studies have discovered an association between stroke and COVID-19 that is still being investigated, though many think this is because of COVID-19's hypercoagulable state. So in this case, we have a 45-year-old Hispanic woman with a past medical history of poorly controlled diabetes type 2, hypertension, grade 3 obesity, and endometriosis. She presented to the emergency department with sudden onset dizziness, nausea, vomiting, and a diffuse headache with photophobia. On physical exam, her vitals were notable for a blood pressure of 166/85. She was mildly ill-appearing and actively vomiting. On abdominal exam, there was mild tenderness to palpation, and most importantly, on neuroexam, there was bilateral nystagmus present, as well as impaired gait. However, there were no other neurodeficits noted, focal or general, and she had 5 out of 5 strength in all 4 extremities. Her pertinent lab values showed a white blood count of 16.2, a glucose of 455, lactic acid of 2.4, beta-hydroxybutyrate of 0.6. Urinalysis revealed +4 glucose with small ketones, large blood, and small leukocytes. A venous blood cast was done and showed a pH of 7.46, PCO2 of 36.3, a PO2 of 73, and as well as a negative pregnancy test, a hemoglobin A1C of a 12.6, and COVID-19 PCR test was found to be positive. That resulted later that day. She was treated in the ED with IV fluids and medications. They performed a CT of the head without contrast, which showed no sign of acute intracranial bleed, as shown in Figure 1. An MRI of the brain was ordered, but was delayed due to the positive COVID-19 test that had resulted later that day. It was delayed up to over 24 hours and was done around 10 p.m. the next day, at which time the MRI revealed an acute right cerebellar infarct. Over the course of her hospital stay, she remained without hypoxia, and initial symptoms had actually initially improved. The patient was transferred after the MRI results around 4 a.m. to a higher level of care and admitted to a neurocritical care unit. At this outside facility, they did a repeat MRI as well as a CT angiogram of the head and neck, which confirmed an acute medial infarct of the right posterior inferior cerebellar artery. Ultimately, after continuing with more tests, the patient was discharged home 2 days later from this facility with instructions to follow up with neurovascular surgery. In reflecting on this case, we have discovered that reports have found vertigo to be the symptom most associated with missed stroke. And COVID-19 has been documented to have an association with stroke due to its hypercoagulable state, but the exact mechanism of this phenomenon is still not well known. And overall, there have been very few case reports of cerebellar stroke presenting as isolated vertigo while having COVID-19 infection. In conclusion, this case demonstrates 2 main points. First, that there is indeed a need for an improved diagnostic approach to acute vertigo. And second, although the correlation between COVID-19 and stroke is still undergoing more research, it is indicated that patients with COVID-19 infection should be more cautiously evaluated when presenting with a symptom that may be due to an underlying stroke. Thank you for listening.